for having me, and to Rick for setting the scene beautifully. I'm going to go through a little of what I just mentioned. So some DCM analysis that I actually presented at BCW last year, and have a little follow-up to share with you. But I also wanted to also look at a small brain network. So these are dynamic causal models for fMRI and EEG in healthy controls, and looking at some phenotypic relations in frontal networks. But to try and motivate why the talks you'll see have networks with 5 or 6 or even 2 nodes, rather than the large-scale brain modeling that we saw in Michael's talk and Gustavo's talk, it would be to motivate generally how we're thinking about modeling the brain in computational psychiatry. And here, what we might be interested in, and this is a useful taxonomy in Flegel's chapter in computational psychiatry, is that we may want to look at normative models. So this is describing how an optimal system would work given the goals. So trying to describe what a brain is trying to do. So things like reward maximization, or we might want to understand process models. So the sort of beautiful deconstructions you've just seen. So what is the mechanism? So how are things done with relations to synapses and cells? And exemplars of the different types of models may be, in a normative sense, understanding the maximization of reward or efficiency, or the minimization of surprise or free energy, which can be cast as a sort of Bayesian brain motif, where we're inferring causal structure in the world, or look more small networks, like how we would model the representation of items in working memory and their disturbance. And then on the process side, we have, again, we have nice models of midbrain dopamine signaling through reinforcement learning, or its temporally extended cousin through dynamic programming. There are other process models like Infamax, and what I'm going to talk about today are the predictive codes that motivate using small networks, because we have a framework in which we can potentially interpret different types of connectivity in the message. Though obviously now I'm thinking about all the lovely thermodynamic arrows of time and how they relate, but we might discuss that later. And so that's why I'm going to present dynamic causal models to try and link the normative and the process. So the DCMs, as you've seen from Rick and Richard's talks, have a neurobiological plausibility. They, as you saw in Richard's talk quite nicely, might be able to go all the way to a receptor and a drug intervention. But how they relate to a normative talk, I'm going to describe through the free energy principle. And so this is just a little recap of how we might arrive at a predictive cortical hierarchy through looking at this normative model of surprise minimization. And Carl is here, so I can quote liberally. So in his theory of cortical responses in 2006, it states that the biological agents perceive and act in order to minimize long-term surprise, and it can predict its world. And so to do so, an agent could model the world and try to predict the causes of its sensations. So we may be like Pedro in Havana, or here in London, where you have a real world impinging on your sensory epithelia and giving you little signals through sensory inputs Y. And what you're trying to do is construct the world in your brain. And we are interested in brain connectivity because we think that the structural connectivity imposes the sort of structures that we see in the world. So this is the classic Feldman and Van Essen diagram from macaque wiring in the visual hierarchy, where we're going from lateral, from the retina to the LGN and regions of the thalamus up into the hippocampal cortex. And it's no surprise to this audience that there's a nice hierarchical structure that lends itself to a sort of bottom of the hierarchy and top of the hierarchy interpretation. And so how we would try and use this scaffold is to try and do inference through effective connectivity, so through the actual signals that are running in this network. And so what the brain might be trying to do, according to the free energy principle, is to try and approximate a rich sensorium described by probability density P with a inferential doesn't quite exist, this density Q, but we're always trying to get Q to match P through the signals that are running on these connections. And so what is your posterior under the free energy? So it's the one that minimizes free energy. And so that way you will minimize incoming surprise, and by making the density in your brain, Q, as close as possible. So we're going to minimize the KL divergence between Q and P, which we can do in a hierarchical sense. So our inference, if we've ever seen a pink car, will tell our brain that this, or our brain will tell itself that this is a pink Cadillac in Havana. Now, if we're learning and we want to fundamentally alter the structure of this model, we would do so under the free energy principle by minimizing the exact same cost function, but we would do so at a slower time scale. And so that's, I guess, another interesting counterpoint to what, or touch point to what Rick suggested of compensatory mechanisms in psychiatric disorders. So if we want to change the structure of the model, not just use it to do inference, then we would change it also to minimize free energy so that we become good Bayesian regulators. But also you can survive under the free energy principle by acting. So if you were Pedro and it was hot outside and walking around Cuba, you could change your data. So because the free energy principle has this negative log probability of incoming sensory data Y, we would like to be able to, if we can't alter our free energy through changing our Q, then we can alter it by changing our Y or making our sensory data more predictable, so to retain homeostatic milieu. So we may move from Havana Center to the bar at El Floridita and get ourselves a daiquiri. And so how this unfolds, and we won't go through the maths because I know I have 2 minutes left or something in the talk, is to this might unfold via a hierarchical message passing scheme. And Michael Breakspear had this icon on earlier. And basically it says that, again, you also saw it in the form, particularly of electrophysiological DCMs, that you might have these distinct populations, which we know exist physiologically and anatomically, but they might be doing particular parts of the normative algorithm. And so what the backward connections may be doing is predicting something like the speed of a car, and what the forward connections out of superficial layers into deep layers may be doing is passing prediction errors. So mismatches between your prediction and your error. And again, by doing this, we can do the inference that I've just described. We can maximize or we can minimize the KL divergence between P and Q and make our brain a good model of the environment. And then sometimes what you'll see is the neuromodulatory systems like dopamine mapped to a weighting on different errors so that our brain is able to pay attention to distinct signals. And again, this might be interesting in the context of the framework that we just heard from Rick. And so what I'm going to show is just this framework in a couple of vignettes. One of them is in a story of You Are What You Eat. And this is data that was acquired in Brisbane with Luca Kochi and Caitlin Hall, who then came to my lab to do some DCMs. And here we're interested in looking at the composition of the microbiome and how it relates to task-based connectivity in fMRI. And then I'll show you another example of how we've extended that into inflammatory bowel disease, speaking back to something Ed Bullmore mentioned on Monday, looking at chronic inflammation models here using Crohn's and also ulcerative colitis as a control. And then I'm going to revisit what I showed you last year and just show you the work on schizophrenia subtypes and how we've extended that into an earlier population. And again, we can ponder how Rick's framework fits or how I've confused things, whichever suits. So first of all, back to You Are What You Eat. So I guess everybody knows that the microbiome is a not now that new, interesting topic, looking at the gut-brain axis and how they impose themselves in states and how they may be related to psychiatric disturbance, if not full disorders, but features of anxiety and depression. And so what we're talking about is 1 to 2 kilograms of microbes, mainly bacterial, where we do see large comorbidity of depression and anxiety with inflammatory bowel disease. So roughly 65% of those with something like Crohn's versus 45% in other chronic health samples will have depression or anxiety. And what I'm not going to get into are the nitty gritty of the pathways, there are many. So vagus nerve is the primary direct transmitter, but there are also many pathways at different timescales through hormonal and immunological pathways, like interleukin pathways that might underpin this particular axis. And this is, I just thought, a nice study to convince you that this is true, or at least meaningful in the context of brain disorders. So when this is an example of different mice, germ-free mice where they've transplanted the microbiome into other animals. And so these NIH Swiss mice versus BAL-B mice were measured in terms of an anxiety feature. So how long do they take to step down off a platform? These guys are pretty intrepid and they're a little more shy, the BAL-B, but if you do the reverse microbiome colonization, then you see that you make the Swiss mice a little more nervous by adding the BAL-B microbiome, and you make the BAL-B mice a little bit more less fearful and a little more intrepid if they have the microbiome of their braver counterparts. So that's a very direct study of the microbiome. Here we're going to do it indirectly, looking at neurocognitive assessments and an fMRI task of fear conditioning. And so the task doesn't use shocks, but uses aversive auditory cues. There's a baseline condition where participants view two different stimuli, a conditioning condition and a reversal condition. And these are just some points to prove that the conditioning task was effective in altering valence and anxiety arousal. And so just looking at the CS plus versus the CS minus, what we can see is a small network. So again, this is why we're going to use a DCM, where there are key regions in the anterior cingulate and also in the anterior insular cortex that show a significant response at whole brain cluster correction. And so what we did was look at connectivity hypotheses from DCM, where we were interested in the bidirectional connections between these two regions through the cingulate and the insula. And we were interested in whether the aversive stimuli elicited changes in connectivity between these two regions, and whether they did it in an event-related way, or whether they changed the sort of state of the brain in a block-based way, or whether both were present. And what we found was that the sort of event, so the punctate response to the CS plus was what was modulated in these connectivity features. So there was a modulation by threat-provoking stimuli. And interestingly, the direction of this threat-provoking stimulus enhancement was bottom up. So the insula to the cingulate cortex was enhanced in the conditioning and reversal phase for the CS plus relative to CS minus. But what we were really interested in looking at was whether the composition of the microbiome had any relationship with, so nothing causal here, though we're using a dynamic causal model to look at the fMRI. So we're just looking at associations with two particular features of the microbiome. So one of them is a little bit unclear in terms of how it relates to psychiatric disturbance. So the bacteroidetes firmicutes ratio is a established metric of the microbiome, and it's been associated with both good and bad things. So low BMI, but also heightened stress response in rodent studies. We looked at a sort of more simply straightforward diversity measure known as alpha diversity, and this is known to be a diverse is good. And has been shown in MDD patients to show reduced diversity compared to controls. And again, what we were looking at using a second level, what we call a parametric empirical Bayesian analysis of DCM, was whether the alpha diversity or bacteroidetes firmicutes ratio was associated at an interindividual level with either of the top-down, bottom-up connectivities, or the intrinsic connections within, so the gain control, if you like, within the anterior cingulate or within the anterior insula. And so what we found was that, this is mislabeled, this is the alpha diversity was the key component in a top-down regulation of the cingulate cortex to the anterior insula. And interestingly, this top-down connection was negative. And it was present particularly in reversal when you were trying to learn that the previously fearful stimulus was no longer threatening. And so what I wanted to just show you was this other framework that has been proposed as a sort of predictive coding allostatic prediction mechanism by Klaas Stefan and Federica Preschner, who looked at a much more extended review of these sort of circuits and proposed a similar thing that we've found here, was that the gut ratio that might be negative, so our bacteria eats, so that when we're doing our fear conditioning, we have this increased bottom-up connection, but when we have a better, healthier gut, we have a top-down connection that's negative, so maybe more explaining away this threatening stimulus in the reversal phase. And what we've done subsequently is look at a resting state analysis of the microbiome and resting state networks using EEG. And very quickly, because I don't have time, I'll just mention that we used the Mark Wilrich temporal delay embedding hidden Markov model to distinguish different states and state occupancies, and found a default mode network difference between healthy controls. And here we're looking at actual patients who have inflammatory bowel disease, and they actually have two types, either Crohn's disease or ulcerative colitis, both IBDs, but Crohn's more chronic in its nature. And by then using this sort of determination of nodes, using a eigenvector centrality measure, we selected 10 regions that were most important in this resting state network for a dynamic causal modeling analysis using the exact same models you've seen in Rick and Richard's talk. And what we were able to reduce it down to, which I think is one of the powers of DCM, is just one connection that was strongest here in one group. So in the Crohn's disease patients, you got a very distinct and selective increase in a connection from the insula to the medial prefrontal cortex. So rather like in the fear conditioning task, is a bottom-up effect, and it was associated with the duration of this chronic illness. And here Crohn's is really seen as the most important chronic remitting inflammatory disorder that shows you that some of these inflammation markers might be associated with chronic long-term changes in brain connectivity here from the insula to the medial prefrontal cortex. Very quickly, in a minute or two, I'll just take you through the second story, which walks back into schizophrenia, where we were looking at subtyping patients with schizophrenia. And I showed most of these slides last year, so I can go through these quickly for those who were there. But simply what we're doing, again, is a task. So this has activations in particular areas. And this is with Suki Shergill, who's now at the University of Kent. And what we were looking at was the response of patients with schizophrenia to emotional faces when the task was yoked with learning a rewarding cue. And modeling it here, reverting back to the sort of reward-based modeling with reward prediction error, what you saw was some obvious regions in healthy control, so caudate and cingulate responding to RPE. And in the emotional contrast compared to neutral faces, what you saw was the amygdala and the fusiform gyrus. And what we did was construct a DCM that had interactions within this network during the task, where faces went into the fusiform and amygdala and RPEs were inserted into ACC and caudate, and looked at how the dynamics unfolded for healthy controls and then for two subtypes of patients with schizophrenia. And what we found was that those who responded to dopamine medications versus those who were resistant to dopamine medications had a higher top-down signaling during this task overall, particularly from the cingulate to the fusiform and from the cingulate to the amygdala, which was absent in the treatment-resistant patients. And again, coming back to breaking down these connections in terms of symptomology, what we saw was that the frontal regions had both positive and negative associations with symptoms, but that this top-down connection per se from the prefrontal cortex to fusiform gyrus, and the stronger it was, the weaker the set of symptoms, both in terms of positive symptoms, negative symptoms, and aberrant salience, whereas those with resistance tended to have interactions with the regions that we were just discussing with Rick into the basal ganglia. So if this cingulate cortex was misguided towards the basal ganglia around the caudate, then you saw an exacerbation of positive symptoms and aberrant salience. And so what we were hoping was that this is a sort of retrospective look at some patients who were subtyped in schizophrenia, those who do and do not respond to dopamine blockade. But we here we're studying patients when they're on their medications. So they were confounded by drug state, and we wanted to look at drug naive patients. We couldn't find them, but went to the next best thing, which were patients at a much earlier course of the disease. So first episode and within a year of diagnosis. And here we were looking at this sample of 35 patients who would go on to be treatment responsive, 18 patients who would go on to be treatment resistant. And what we found was that at region, the cingulate cortex connectivity implicated again, but in the other direction. Again, to sort of complicate the nice, elegant model that Rick showed, but again, here in a different modality, looking more indirectly at fMRI data, what we showed was that the treatment-resistant patients had a high coupling with the amygdala and the ACC for the network connection through a DCM. And so what we think is that differences may be due to stages of the illness, again, which has been investigated a little in the context of prefrontal gamma oscillations by Peter Ullhaus's group. So our findings from the small brain networks are not to just try and keep our data size small for small sake, but to try and relate the connectivity differences to frameworks that allow us to interpret some of the behavioral features that we see in the diseases. And so with our you are what you eat analysis, looking at the insula and ACC, we saw that if you have less top-down control of the insula, and then potentially you might be anxiously appraising all stimuli. Whereas in the case of Crohn's disease, again, from a whole brain analysis using EEG, we were able to identify again that same small two-node network that was the key distinguishing feature between the three groups, from chronic inflammation to those with an IBD that wasn't so chronic and a healthy control. But then looking at schizophrenia subtypes, again, using DCM as a small network where we can try and unpick some of the features of learning here in the context of reward learning, what we seemed to see was that the cingulate cortex did slightly different things and seemed to be a key node. And again, perhaps reminiscent of what Rick showed in those analysis around the IFG, but here in the cingulate cortex, that was a key feature of the distinguishing of patient subtypes in terms of treatment resistance and treatment responsive, but also that actually the sign of the connectivity flipped from the early to the late, but unfortunately we were going from high E to low E, so not exactly as Rick outlined, but similar. So to leave a few time for questions, hopefully there is some. I'll thank these wonderful colleagues and you for your attention.
Thank you very much for